reflex. We will then illustrate various eye movement abnormalities, some common and some rare, that may be encountered in patients with vestibular disorders. We will not demonstrate the remainder of the neurological examination, realizing, of course, that a complete neurological examination of cranial nerves, gait, strength, reflexes, coordination, and sensation is essential for the proper diagnosis of patients who have dizziness, vertigo, and imbalance. Corrective movement because the eyes are slightly exophoric. And if there is an ocular misalignment, we then check for it, look at the light, in other positions of gaze. Then I usually test convergence. Look at the tip of your fingernail, just this one. Try and focus in on it and look right at it. Try hard. Look right at it with both eyes. And there she can converge. Look at my nose. Look at your finger. Nose, finger, nose, finger. All right, now we're going to check for nystagmus in eccentric positions of gaze. So we'll ask the patient to look far to the left. Good. Far up. Far to the right. Far down. And usually I look down and laterally as well, where downbeat nystagmus can sometimes be brought out. Okay, good. Then we look for gaze-evoked nystagmus. Just hold your eyes there. Look up. Look laterally here. Look down. Look straight down. Right at the pen. Down. Straight ahead. Then we'll look for rebound nystagmus. Have the patient hold their eyes in an eccentric position for maybe 25 or 30 seconds. Now look right at my nose. Nice steady fixation at the end of that gaze holding. In the other direction, 25 or 30 seconds. Look right at my nose. Next, we'll check for saccades. We'll look at refixation ability, the speed, the accuracy, and the latency of the movement. Look at the pen, and look at my nose. Pen, nose. Pen, nose. Pen, nose. Pen, nose. Look down at the pen, look at my nose. Pen, nose. Pen, nose. Pen, nose. Pen, nose. Look at the target, look at my nose. Target, nose. Pen, nose. Pen, nose. Pen, nose. Pen, nose. Now we'll look for some bigger ones. Pen, finger. Pen, finger. Pen, finger. Now we'll look vertically. Pen, nose. Pen, nose. Pen, nose. Pen, nose. There's occasional slight downward overshoot, which is normal. You can also see it with the lid. Next, we'll check smooth pursuit. We ask the patient to follow a target horizontally. Look for the smoothness of the movement and for any catch-up saccades or rarely a back-up saccade. Her tracking is quite smooth. Don't go too fast. And then we do it vertically. Okay. We can also look for lid lag here. Pursuit is relatively smooth. Many normal subjects have some difficulty tracking downward smoothly. Now horizontally, it's quite smooth. Next, we'll do optokinetic testing. We ask the patient to follow some targets on an optokinetic tape. Look at the little dinosaurs on the tape, and we look for the slow and quick phases of nystagmus, and she has quite a good optokinetic nystagmus. Open your eyes widely. Keep your eyes wide open. That's quite good horizontal nystagmus. Okay. Very good. Slow and quick phases. Okay. Now we'll test vestibular suppression, and we'll ask the patient to keep her eyes fixed upon a target that's moving with the head. That's very good. Keep your eye right on the target, and you can see the vestibular reflex is canceled. Her horizontal fixation is quite steady. And she has very good vestibular suppression. Vertically, right at the tip of that pen, perfect. Next, we'll begin the heart of the vestibular examination. And the first thing we're going to do is a doll's head maneuver, where we ask the patient to fixate a target and we look for compensatory slow phases of nystagmus. And first we do it slowly. Look right at my nose. Fix right over at the camera there. Nice and smooth slow phases. And we do those torsionally as well. One can see the torsional quick phases. Then we're going to do rapid head thrusts, trying to elicit a compensatory response to a high acceleration stimulus. And we ask the patient to look right at my nose, and then we hold the patient's head tightly, and then we move the eyes to an eccentric position of about 20 degrees, and then we quickly move the head back to the primary position, looking for any catch-up saccade. And she's really virtually right on target. Look right at my nose, right at my nose. And if there should be a defect in one direction, that would point to a peripheral lesion. Right at my nose. She has nice compensatory slow phase. Usually bring the eyes out about 15 degrees eccentric and then perform the head thrust, bringing the eyes back to center. Good. And we do that vertically. Right at my nose, which is quite good. Now look right at my nose. Here's a head thrust sign now in a patient who's lost function in the left labyrinth. We're going to ask him to first look right at the camera and look for the smoothness of those movements. And at low speeds, they look quite good. Now we're going to move them a little more quickly. Look right at the camera. That was eyes wide open. Perfectly normal when he goes to the right. Look at the camera. Catch-up saccade when he moves his head to the left. Normal when he moves his head to the right. Normal when he moves to the right. Next, we'll put on some Frenzel lenses. Again, this allows us to eliminate fixation, and so bring out any vestibular nystagmus or vestibular responses. It's the equivalent of doing the Romberg test for posture. These lenses are plus 20. They allow us to see in a magnified view, and the patient's vision is blurred and has nothing to fixate upon. Put these glasses on, and then normally we would shut all the lights off completely so the patient can't see anything through the lenses. And just to give one an idea what one is looking at, keep your eyes wide open. Few small saccadic movements, square waves, which is quite normal. Then I have the patient look to the right, far right, left, straight, look up, look down, straight ahead. Here is an example of the use of Frenzel lenses to bring out a spontaneous nystagmus. This is a patient in the throes of an attack from Meniere syndrome. See the spontaneous nystagmus beating to the right behind the Frenzel lenses. The lenses are removed, and now fixation is steady. No nystagmus is seen. The lenses are on again, and the nystagmus reappears. Now, just to show the types of head maneuvers we'll use with the Frenzel lenses, first thing I do is I have the patient look straight ahead, and then I apply tragal compression to see if there's any nystagmus elicited with a change in pressure in the external auditory canal, such as might occur with a fistula. Look for nystagmus and ask the patient if it makes them dizzy. Are you dizzy?
No.
Okay. Both ears. Again, looking for nystagmus. Then I ask the patient to take a deep breath, hold it in, and give me a strain. Eyes open, looking for Valsalva-induced nystagmus. Relax, which might occur with a fistula or cranial-cervical junction anomaly. Next, we'll see an example of a patient with Valsalva-induced nystagmus. In this case, the nystagmus arises from a disorder of the ossicular chain. Valsalva-induced nystagmus can occur with other middle ear disorders, perilymphatic fistulas, and cranial-cervical junction anomalies. Now we're going to see the patient Valsalva, and you'll see a predominantly upbeat with a slight torsional component nystagmus, and when she relaxes, we see a nystagmus in the other direction, predominantly downbeat with a slight torsional component. Now we'll see this again. Valsalva with the upbeat nystagmus with a slight torsion, and then relaxation with a downbeat nystagmus with a slight torsion. Here's an example of noise-induced nystagmus or Tullio's phenomenon. In this case, the disorder reflects an abnormality on the ossicular chain. First, we will hear a sound and look at the nystagmus induced by the noise.
Now moving to a longer duration.
Then I do head shaking, and I usually pitch the head down about 30 degrees, and I'm going to shake the head back and forth about 30 times and then look for a spontaneous nystagmus after the head shaking is completed. And you can have the patient close their eyes during the head shaking. Close your eyes, and I shake the head vigorously. In elderly people, I'll often ask the patient to do the shaking themselves. You can give me a hand here. When I'm finished, I just say, stop, eyes open, and I look for any spontaneous nystagmus. And there is none. Then I do this vertically. Close your eyes. Okay, stop, eyes open. Our patient is now shaking the head rapidly back and forth. The head is pitched down about 30 degrees to put the lateral canal roughly in an earth horizontal plane. And then we look for the nystagmus induced by the head shaking. And it's a right beating nystagmus with a slight torsional component, slow phase toward the paretic ear. The nystagmus then stops. The eyes are still. But if we wait, we will then see the reversal phase of nystagmus. And now the nystagmus begins to beat slightly to the left. This is the reversal phase of head shaking induced nystagmus. Now we're going to put these glasses on after she hyperventilates. I want you to go like this. Deep and fast about 30 times. Go ahead. Okay, stop, eyes open. We look for nystagmus, and we ask the patient if they got dizzy or if the hyperventilation reproduced any of the symptoms that they had before.
No.
Next, we'll see an example of hyperventilation-induced nystagmus in a patient with a left acoustic neuroma. Note that the nystagmus appears to be emanating from the left side. It's an excitatory nystagmus. Here's the patient during straight-ahead fixation.
Okay, start hyperventilating. Deep and fast, real deep. Okay, here's the nystagmus. And stop. And there's a nystagmus with the quick phase clockwise, primarily torsional with a slight downbeating component.
Next, we will show the positional testing maneuvers. Normally, this would be done with Fresnel lenses, but here we will show the maneuvers without. First, we turn the patient's head to the right 45 degrees and put the head down to stimulate the posterior semicircular canal on the right side. Then we bring the patient's head up. Then we turn the head the other way to stimulate the left posterior semicircular canal. Then we bring the head up. Then we put the patient's head straight and bring her back to the head hanging position. Now from this position, if there is no nystagmus, we then bring the head up and turn the head over onto the right ear to look for a horizontal nystagmus. If the patient has arthritis, we will turn the whole body over to the right. Then we bring the head over to the left ear down position, again looking for a nystagmus. Then we bring the head back and then bring the patient up. Next, we'll see an example of positional nystagmus caused by benign positional vertigo of the right posterior semicircular canal. The patient will be wearing infrared goggles which are attached to the head. Here the patient is sitting upright. We're looking at spontaneous eye movements. First, the patient's head will be turned to the right about 45 degrees here, and then the patient will be put down into the right Dix-Hallpike position. Now we will see the nystagmus, mixed vertical torsional nystagmus emanating from irritation of the right posterior semicircular canal. It's there in the primary position. When the patient looks to the right, it's predominantly torsional. When the patient looks to the left, you see more of a vertical component, and then the patient looks straight ahead again, and you see the mixed vertical torsional nystagmus, which is slowly dying out. Here is another example of a right posterior canal BPPV. In this case, there will be no Frenzel lenses, and the nystagmus will be less obvious. But if you look carefully at the torsional movement of the globe by focusing on the conjunctival vessels, the nystagmus will be apparent. We're first going to see the patient just as she has been brought down into the right Dix-Hallpike position with the right ear down. Note the nystagmus. A few beats of a torsional nystagmus. Watch the blood vessels. We'll see this again. A few beats of a torsional nystagmus. Watch the blood vessels. Next, we'll see the particle repositioning maneuver for a right posterior canal, benign paroxysmal positional vertigo. The patient's head is first turned to the right, about 45 degrees, to maximize the stimulation of the right posterior canal when we put her head down in the right Dix-Hallpike position. The patient's head is then brought down. One looks for the nystagmus. This can usually be done with Frenzel lenses. Then the patient's head is turned about 90 degrees toward the other side. One again looks for any nystagmus. It should be in the same direction as the initial nystagmus with the right ear down. And then the patient is turned over again another 90 degrees with the head almost looking down at the floor. Then the patient's head is brought up. Hold on to the patient. They may feel slightly unsteady, and this completes the particle repositioning maneuver.